Good evening to all
Good
of you.
evening. Thanks, Vinay, for the session on childhood acute lymphoblastic leukemia. So, no introductions needed. Dr. Vinay is the associate professor,
No, I'm currently in
the
Bangalore.
consultant pediatric hematologist. Okay. So he's a consultant in pediatric hemato-oncology. We are going to discuss childhood acute leukemias today, and his staff nurse Lakshmi is going to discuss on administration of chemotherapy supportive care in childhood ALL. So over to you, Dr. Vinay.
Thank you, Dr. Dharini. Hello to all of you. So today, I think we are talking a very relevant topic on International Childhood Cancer Day. So what we'll discuss in next 30 minutes is just go through journey of how a child goes through treatment of acute lymphoblastic leukemia. So let us be very simple, basics, and what we practice, no much of theory. So, as we all know, today is International Childhood Cancer Day, and unveiling challenges is the theme for this year. The commonest cancers, if we see, the most common cancer is leukemia, and I'm sure all of you managing children with cancer spend 75% of their time managing ALL only, and also 75% of inpatients are ALL, and probably we are very happy treating these kids because they come out very doing well. So ALL is one of the commonest tumors in childhood. So unveiling challenges in ICCD 2024, I just thought we should know what challenges we have, and most important challenge I feel is the referral delay that is happening. See, we as a community, the doctors and nurses, are now very well aware about how we treat patients, and we know that children with cancer are curable. But you know, in India, the referral rate is so poor that only 49% of childhood cancers reach the hospital. Close to 50% remain undiagnosed, and our survival rates in childhood cancers is 40%. So we just did a study also a year back where we saw that median distance from where children are traveling is about 160 kilometers, and symptom to onset, symptom to diagnosis delay is more than 55 days. So that means a child is taking about 2 months for the child to reach the hospital. And you know, the commonest cancer that we are looking at is ALL. So it's very important that we understand how ALL is. At the end of this session, all the nurses practicing in pediatric oncology unit should be able to further educate the community as well as their friends about the simple things that may help us understand that what ALL is. So basics first. So where is blood produced from? It is produced from bone marrow. So bone marrow is a tubular structure inside long bones. It is not just made up of blood, it is made up of fat, it is made up of various cellular components. And you know that the most important cell component of blood is red blood cell, white blood cell, and platelet. So in normal blood, the left side picture is normal blood where it's mostly red in color. That's why blood is red, because RBCs are the prominent one. But what happens in leukemia? Leukemia means leuke means it is white, and leukocytes, you know, is white blood cells. So when the leukocytes increase in blood, it is called leukemia. And these leukocytes are not normal; these are abnormal leukocytes. So the picture on the right side is how a peripheral smear of a leukemia child looks. So what is leukemia? It is a problem wherein the progenitor cells, the stem cells of the in the bone marrow, develop develop capacity to indefinite self-renewal, and this results in poorly differentiated hematopoietic precursors, which we term as leukemia. So to define leukemia, no, it's abnormal clonal proliferation wherein the precursors accumulate in the bone marrow more than 20%. So one learning that I would like to say from this slide is, if you see a bone marrow report with abnormal cell more than 20%, you are sure that it is leukemia. Leukemia is of two types. Common one is acute leukemia, which can be acute myeloid leukemia or acute lymphoid leukemia. The one that we will discuss today is acute lymphoblastic or lymphoid leukemia. So we know here that stem cells can differentiate into lymphoid progenitors and myeloid progenitor cells. So lymphoid progenitor cells differentiates to become B lymphocytes and T lymphocytes. So when you see a blood picture, there will be hemoglobin, there will be white blood cell, there will be platelet. In white blood cell, there will be neutrophil. You must have heard about lymphocyte. So the lymphocyte is produced from what is called as lymphoid progenitor cells. It gives rise to B and T lymphocyte. Just remember box area. When the lymphoid progenitor cell becomes abnormal, they proliferate without any stop, and it accumulates inside the bone marrow and spills into the blood, and it is called leukemia. Okay, so pediatric leukemia, as I already told, is the commonest blood cancer, 30% of all cancers in childhood, and peak incidence is between 2 to 10 years. 75% of leukemia is ALL, what we are discussing today. In 75% of that, 85% of them are B cell ALL and 15% is T cell ALL. So you understood that lymphocytes give rise to B cell and T cell. When the progenitor, B cell progenitor becomes leukemic, it's called B cell leukemia. When T cells become leukemic, it's called T cell leukemia. So now we'll go stepwise how we approach. So these are the learning objectives. We'll go with few diagnostic clues, and there'll be learning points at the end of every 2 slides approximately. Okay, few cases we'll discuss. This is a 4-year child with progressive pallor, bleeding from nose and neck swelling. Child has received 1 blood transfusion at a nearby hospital, and doctor says there is hepatosplenomegaly and lymph nodes are palpable. This is one case. The next one, 10-year-old child coming to the emergency with cough for 15 days. And the photo is there on the right side where you can see the neck swelling is there, and child is breathing very difficult, like with his mouth open. And there is an X-ray that is there downstairs, down, which is showing a mediastinal mass. Third case, 12-year male child coming to ER with fever for 10 days, and they come with the blood picture where the total leukocyte count is 7 lakhs. Okay, so what are the possibilities in all these 3 things? Having looked at this, nurses in heavy volume centers would already have identified these are a leukemia, but let us go stepwise to identify. So what are the most important clinical signs that we see? Fever is the commonest thing. Fever for more than 2 weeks should always alarm us that it may not be infection. Apart from that, bleeding from any side, bruises. The photo on the right side is showing. Joint pains or bone pains, limping is one of the classical signs, and lymph node palpable or hepatosplenomegaly is another thing. Okay, this is the common history that we get. So coming back to case 1, now we'll go through this. Let us label this child as master A. So this child A is 4-year-old, progressive pallor, epistaxis, swelling, 1 blood transfusion, lymph nodes and hepatosplenomegaly. So you saw the history in the previous slide. So he is actually fitting into something that we may think it is involving the blood. That's why there is low hemoglobin pallor, then bleeding is there, and also lymph nodes and hepatosplenomegaly. All of them are something called lymphoreticular system. So when that is involved, you should think as pediatric oncology nurses that we are dealing with something that is malignant, maybe leukemia. So what next will we do? So the first thing that we will order is a complete hemogram, because we saw there is bleeding and pallor. So we want to see what is the blood picture like. And whenever we order a hemogram, we should always ask for peripheral smear. So this is the report of the child. The hemoglobin is 4.9, WBC is 27,000, platelet is 6,000. So all of you are now very well aware about what are the normal values. So you can see hemoglobin and platelet are very low, WBC count is high. So, and also you can see the neutrophil is just 1%. It's very important for us to ask the peripheral smear, and it was reported in this child that there was 30% blast or abnormal cell. So this is the peripheral smear how we look at, and you can see that as I showed you in the first slide, an animated cartoon. Here we can see that there are big blue cells with small amount of cytoplasm and big nucleus. So these are called blasts. So whenever a pathologist sees, then he will report it as abnormal cells. This is not normal. So once we see circulating blast, it is always acute leukemia. So the learning point 1 here is, when you have suspicion of leukemia, you send a CBC and ask peripheral blood. If peripheral blood smear is showing circulating blast, there is no other diagnosis except leukemia. So it doesn't need a doctor and an admission to diagnose this. Just a peripheral smear is enough. And when you see blast circulating in peripheral smear, then nurses should always be able to say it is leukemia. Now next, once you know leukemia, what next? We have to assess further. We look for some clinical signs. The doctor looks at some mucosal bleeds, gum hypertrophy, testicular enlargement, examination of some other lymph nodes and skin and things like that. So complete systemic examination has to be done. Most important here is, there are few things that in leukemia we have to look at. One is testicular enlargement in children, with boys, because it can get involved in about 3 to 5% of cases. In ALL, boys with ALL can have testis enlarged. Apart from that, gum hypertrophy sometimes is seen And this is not uncommon because can come with other common non-cancerous condition as well, like scurvy, gingivitis, some drugs and all. But from your side, if you are examining a newly diagnosed leukemia, nurses should be able to just open the mouth and see if there is gum hypertrophy. This is another photo where it is called chloroma. This is nothing but the left eye looks propped up, proptosis is there. So chloroma is also some leukemic deposit that may not be in the blood. It's extramedullary. So it can come sometimes. So these are few clinical signs the doctor may examine. Even you should be able to identify these abnormal signs and relate it to leukemia. What next? So before we establish and confirm the diagnosis, what we have to do is admit the child and stabilize. So here, child had a hemoglobin of 4.9. We always try to keep hemoglobin more than 8 because we need to give good amount of IV fluids. Hyperhydration is required. So we do not want the child to be anemic and having cardiac overload. Platelets also was low. Maybe he needed platelet. The next is we should start IV fluids and hyperhydrate the child. Whenever IV fluid is written in a newly diagnosed leukemia, we should always say it is potassium-free fluids. If the doctor doesn't write, nurses, you should be able to get back and say potassium should not be there in the fluid. Then we should monitor urine output and then add allopurinol. This is one of the drugs that we add in the first week of treatment of any child with ALL to prevent something called tumor lysis syndrome. A chest X-ray we should always do before we do any procedure on the child, because you saw in one of the case, the X-ray had a big mass which may compress the trachea and it may actually cause respiratory distress if you sedate the child. So things you have to understand is any child that is coming with the newly diagnosed of leukemia, admit and stabilize. So anti-tumor lysis measures, which is starting IV fluids, monitoring urine output and allopurinol is very important. So learning point 2 is any kid with leukemia, refer if it is not a pediatric oncology unit. If it is a pediatric oncology unit, admit, stabilize and work up. Now next, what workup do we do? So to establish diagnosis, the first thing we do is blood investigation. It's a cancer of the blood. So blood test is very vital here. What I would say is whenever you are cannulating, see kids, it's very difficult to get blood samples. It's very difficult to cannulate. So when you are cannulating, be prepared to know what samples have to be sent. So you should always ask the doctors what all samples you want, because I don't want to prick the child again and again. So you should take complete blood count with peripheral smear. LDH is one of the serum sample marker where it shows the tumor burden, and blood chemistry is to look for tumor lysis syndrome, which includes renal function test, calcium, phosphate and uric acid. So this much you have to do. So a EDTA sample, a serum sample, when you are putting the cannula is very essential. If cross match is required, little extra EDTA sample may be beneficial. So once you know the initial blood test, how do we confirm the diagnosis of leukemia? So to confirm, you all may be handling patients undergoing bone marrow. See, as I told you in the initial slides, blood is produced from bone marrow, which is the factory. So if the factory is not working properly and it is infiltrated with bad cancerous cell, it's better you go to the factory and get the sample and see what type of bad infiltration it is. So bone marrow is done in children under sedation with monitoring, and it is done in either left lateral position or prone position, and we always access the posterior superior iliac spine. I'm sure most of you will be assisting, and many of the sisters who are well experienced will be doing it independently, and I'm sure even you will be participating in bone marrow harvest for kids undergoing transplant. So it's not a big procedure, but still for others who may not know, this is how we do. So you can see a photograph of one of the kids that we were doing marrow yesterday. There are two prominent positions that we can see, which are the posterior superior iliac spine. It is quite swollen there. So if you position the baby properly and sedate him, easily you will be able to find the posterior superior iliac spine. Once it is done, it is very simple. A very small 18 gauge or 16 gauge bone marrow aspiration needle is used, and you will immediately able to aspirate the marrow. And once we take the marrow sample, what we do? So we do three things. Three samples have to be sent from bone marrow. One, we have to make slides to know the morphology, that is something similar to or corresponding to the peripheral smear of peripheral blood. It's the bone marrow smear of bone marrow aspirate. Then you need to take good amount of sample for in EDTA vial for flow cytometry. I'll explain what it is. And you need to take few samples for genetic testing, which will be sodium heparin vials and also EDTA. So what I would do is I would take an aspirate, give it for slides preparation. Then I will take a repeat aspirate, take 1 to 2 ml into EDTA, 2 to 3 ml into heparin vial, and then I would next go to biopsy, get the biopsy in formalin, and I close my bone marrow examination. This is the bone marrow procedure. So this is how we do. So you should be very much aware about what samples to collect. So once we do the bone marrow smear, this is how it looks. The bone marrow smear is completely filled with sheets of these cells, which are huge, small cytoplasm and things like that. You don't have to worry because the pathologist will be able to tell us immediately that it is leukemia. They will do some staining of the slides, and in acute lymphoblastic leukemia, the staining that will be positive is something called periodic acid shift, PAS, and that one thing which will be negative is myeloperoxidase. So you may get a bone marrow report saying that the aspirate is having sheets of blast or malignant cells, and the PAS is positive, MPO is negative. At your level, when you are working in pediatric oncology unit, you should be able to read these things and you should tell the diagnosis. So PAS positive, MPO negative, and morphology is like lymphoid is very likely to be acute lymphoblastic leukemia. You should say it is acute lymphoblastic leukemia. See, the time that we require to get this report is less than 24 hours. So from the time of admission, this thing can be confirmed within 24 hours. But to confirm which type of acute lymphoblastic leukemia it is always better to, it is a must to do flow cytometry. You remember we took EDTA sample for when we did the marrow, that is where that sample is sent for flow cytometry. And flow cytometry is a quite complex procedure. We will not explain it now. But in that, you will be able to identify which immunophenotype it is. Either it is a B cell lymphocyte or a T cell lymphocyte. The timeline to get this report is 24 to 48 hours. So once the child reaches a center, the diagnosis should happen, including which type of ALL it is, within 24 to 48 hours. And I'm sure most of the centers in India which are practicing pediatric oncology is doing. So nurses in pediatric oncology unit should be able to educate other nurses and the pediatricians that fever of prolonged duration with these symptoms may need a bone marrow, because we get the diagnosis within 24 hours. The immunophenotype, there are few markers that are there based on which we will know it is B cell or T cell. I will not explain the markers. It is there in the slide. But in this child, the child had a pre-B cell ALL. So the immunophenotype was confirmed. It is pre-B cell ALL. So at the end of bone marrow, within 48 hours, we'll be knowing that it is a leukemia, it is a lymphoblastic leukemia, and it is a precursor B cell lymphoblastic leukemia. So you just remember this. When you see the bone marrow report, ask for a flow cytometry report. And in the bottom line, in the impression, based on these markers, the pathologist would have commented that it is a B cell or a T cell ALL. This report you have to always see. What next? See, the learning point 3 is systematic workup gives us complete diagnosis within 24 to 48 hours. So always try to be more systematic when you are doing the workup. So you remember we took samples in the green tube as well. We like to do some cytogenetic testing on that, because this is one of the prognostic markers in ALL. Over decades, it has shown that if you treat based on the genetics and few other prognostic markers and treat it based on risk stratified method, the outcomes are excellent. So when we look at the number of chromosomes, we look at some translocations and all, no need to understand, go into depth of genetics, but you just understand if the number of chromosomes are high, more than 50, hyperdiploidy, then it is good prognostic factor. If the number of chromosomes are less, hypodiploidy, less than 44, it is not a good prognostic marker. There is one translocation called ETV RUNX1. If it is there, it is a good prognostic marker. Trisomies that are there, 4, 10, 17, if it is there, it is a good prognostic marker. So what we do is in the green tube, when we send, either we do a RT-PCR to look for translocation, or something called ALL FISH panel. FISH means fluorescence in situ hybridization. We send a karyotype. We also look for ploidy, whether hyperdiploid or hypodiploid. So based on that, we will get to know which prognosis, how the child may fare based on the genetics of these blast cells. You should remember, this is not genetics of the family. It is just the genetics of the blast cells. So family may just get concerned whether it is genetically transmitted. So it is not genetically transmitted. It is only the genetic mutation that happens in those blast cells which we are planning to treat and eradicate. The timeline to get this test is about 10 to 14 days. Now, in ALL, time tested, see, ALL is a poster boy of childhood cancers, because the outcomes have become excellent in years to come. It was 20-30% about 50 years ago, and now it is more than 90%. One of the most important things that has helped us is to risk stratify and treat. So you should not give very intense treatment to a good prognostic child, and you should not give very low intense treatment for a bad prognostic child. So you should always understand what is risk stratification. So one simple risk stratification is something called NCI classification. So when the child comes, if you see that the white cell count is more than 50,000 and age of the child is more than 10 years, then it is high risk. You must have seen so many kids with ALL, but always try to analyze whether they are NCI high risk or standard risk. For this, you should know the baseline presenting white cell count and what is their age. Both of them you will know on the day when they step into the hospital. But it is always good to keep when they come for the daycare visit, just keep thinking whether this child is a high risk NCI high risk child or a low risk based on the age. The child being more than 10 and WBC counts more than 50,000 at presentation is a high risk. Okay, but we tend to see more kids in the standard NCI criteria. There are few other risk stratifications that we look at. Just when we think about the patient that we were thinking, it was a 4-year-old child. So age was between 1 and 10 years. The white cell count was 27,000. So it is a NCI standard risk. And this child did not have any big liver and spleen and things like that. So at diagnosis, he was fitting into something called standard risk. Now, there are few other markers where we see response to treatment and then risk stratify this patient. So steroid response is one important thing. Cytogenetics we discussed is another important thing. And 35th day we do, after first cycle of chemotherapy, we do a bone marrow and see for MRD. I'll explain that in next few slides. So in this child, the child had a very good genetics and it was a precursor B-cell ALL. So he was child of between 1 to 10 years, less than 50,000. So he was a standard risk to start with. Now, learning for risk-based treatment of ALL has improved outcomes. Cytogenetics is very important for risk stratification. So when a doctor is performing bone marrow, ask him, are you taking sample for cytogenetics also in case it turns out to be leukemia? Many times we may do a marrow for some other cause and it turns out to be leukemia. Then if you have not taken a genetic sample, we have to go back and do the bone marrow again. So it's good for nurses in pediatric oncology to question the doctor, asking whether they have taken sample extra for cytogenetics if at all it turns out to be leukemia. Okay, next. So once we know this is a precursor B-cell standard risk thing, we should start the treatment for this child as early as possible when the child is stable. So what do we start? It's something called chemotherapy protocol. What do we mean by protocol? It is a combination of drugs which has been time tested or trialed to have maximum efficacy. That means the survival from the cell kill of malignant cells would be maximum so that the child survives. At the same time, the side effect should not be more. So minimize the treatment related mortality. So this is how we choose a protocol. And in India right now, we have a trial which has been used and adopted in many centers, and it is called iCycle trial. So this is one of the ALL treatment protocols that is used. There are other protocols like BFM, UKLL and things like that. But we'll just look at iCycle protocol charts to understand what drugs are there. More or less all of them are overlapping and it is all risk stratified. Okay. Very quickly, what are the phases of treatment? So till now, what did we learn? How we diagnose a child, how we suspect a child, how we diagnose a child with ALL, and how do we risk stratify. Now we look at how do we treat. So we adopt a chemotherapy protocol and try to stick to it with with clinical and individual decisions as well. The phases of ALL treatment include the first cycle is called induction. Here we want to decrease the cancer burden by maximum. So it will be logarithmic decrease in the cells. So at the end of 1 month, we want to bring down the blast percentage, which is like 90-95% of the bone marrow, to less than 0.01%. So it's a very important cycle where we want to completely eradicate, most of the disease and try to establish normal blood production back in the factory. The second cycle is called consolidation, where we use other drugs, some different drugs, so that we can minimize the drug resistance. It is for a duration of 2 months. Then there is interim maintenance, which is also to stabilize the disease for about 2 months. Then the next cycle is called delayed intensification or called reinduction, where we use the drugs very similar to the first month so that the outcome is good. And then there is a prolonged 2-year phase of maintenance, where we want to keep the bone marrow not to proliferate very much so that new cancer cells do not generate. So if we treat like this in ALL, the outcome seems to be the best. That is what we have learned over years. And the duration of treatment for ALL lasts over a period of 2.5 years, which is divided into intense phase of 6 to 8 months and maintenance phase of 2 years. Now, at the end of first month, a very important test called MRD is done, which is on day 35. So let us go with this child now. This child was started on induction treatment as per standard risk. So this is how the proforma is. So standard risk, induction, consolidation, interim maintenance, and then intensification and maintenance. Now, let us see, the child is very happy because it was standard risk. Now, at 8th day, we look at something called steroid response, and we look at CSF as well. So steroid response means when we just give steroids, the child has to clear the blast from the blood. So that is called blast clearance, and CSF should be negative for good prognosis, but 5% to 10% of kids can have CSF positivity, where we call it a CNS disease. So learning here is, ask the doctor when you start induction treatment, what has been the response to prednisolone treatment? What is the day 8 blast count? This gives us an idea about response to treatment within 1 week of starting the treatment. This you can ask. So here the child responded well, so the child is happy. So the first month drugs include 4 things. Lakshmi in her presentation will talk about the drugs. So it is mainly vincristine, L-asparginase, steroids, and methotrexate. Then the child goes through 4 weeks treatment. Very frequently seen problems in induction is neutropenic infection, thrombocytopenia, and anemia. Learning 6 is supportive care. Supportive care point 1 is blood component thing. We try to maintain hemoglobin more than 8 and platelet more than 20,000 throughout the intensive phase of treatment of ALL. This case, the child goes through 3-4 weeks of induction, and then at 4th week comes to the ward at 3 a.m. with severe epigastric pain and vomiting, and the BP is low. What may be the diagnosis? There is no fever. One thing we always think is it may be infection, septic shock, and things like that. But just to break the suspense, it was pancreatitis, and we know there are few drugs that can cause. So L-asparginase is one of the drugs which can cause pancreatitis. Very important to admit this child. In induction, any child coming at middle of the night means there is definite problem. So please do not neglect a child coming to the hospital in induction. When the mother says that child is not looking well, you have to take it with a lot of gravity and think whether you need to admit the child and evaluate. So subsequently, the child goes through and comes to the end of the month. Child recovers from that episode. At the end of the month, what we do is something called bone marrow aspiration to look how the response to first month treatment is. So here we do something called bone marrow morphology as well as MRD, minimal residual disease. So what you need to understand is first month's treatment is very important to know how the child will do later. So you can see in the photo on the right side, there is a graph where the cell count comes from a very high peak down, and it can come till the green bottom, or it can just stay here, but it will say that the MRD, the morphology is less than 5% at this point. But when we look at MRD, we know that it will become less than 0.01% when it is in the green zone. So cure is achieved only if we can give a deep MRD remission or deep MRD clearance. So what MRD report we are looking at is something called less than 0.01% at the end of 1 month. So 0.7 learning is single most important response in ALL treatment is MRD. Okay, now this child had an MRD of 0.5%, so it became high risk. So the child was not happy. So the child protocol was upgraded. So you saw when it is high risk, we changed the protocol, and we had to upgrade it to the next consolidation, high risk consolidation, high risk interim maintenance. So these are the drugs and the chart in high risk augmented consolidation, where we use different drugs, cyclophosphamide and cytarabine. This is, as I told you, consolidation is to break the resistance that is developed, and we change the drugs and prevent drug resistance. And we also consolidate means make it more stabilized so that all the microscopic disease also gets eradicated. This child comes in second phase with features suggestive of pneumonia and CT scan showing multiple nodules. And the child was diagnosed with invasive aspergillosis, and we do few tests to diagnose it, and we treat them appropriately. But a fungal infection is quite difficult to treat, and the child has to stay on antifungals for 6 to 8 months. So very important for us to keep the neutropenia and infections under control. So sometimes in consolidation, we use antifungal prophylaxis. So important for nurses to know is neutropenic infection, important to check the vitals. golden hour antibiotic administration, very important. Sometimes we give the antibiotics in patient's hand, and when they come to the hospital, within half an hour we should administer the antibiotics. There is a lot of difference in the incidence of septic shock and ICU admissions if you do this promptly. Learning point 8 is supportive care. Again, infection control. Prevention is better than cure. We'll move on to the next cycle. The next cycle is called interim maintenance, where we use high dose methotrexate. Child gets admitted to the hospital. I will skip this case scenario. Lakshmi will be explaining how high dose methotrexate is administered. So we'll go ahead, but it needs meticulous monitoring and administration. So few frequent things that we come across nurses should address will be something like mucositis, gastritis, diarrhea, some mood fluctuations, ineffective coping of the child. It's very important for us as a team to take care of holistically for the child rather than to just do scientific treatments. So supportive care 3.3 is meticulous administration of fluids and drugs and give good support to the family. Moving ahead, reinduction or fourth cycle is called delayed intensification. We use similar drugs as what we use in the first month, and it takes about 1.5 to 2 months for us to clear that. So once the child goes through that, the child enters the fifth phase, which is called the maintenance phase. So maintenance is one phase where it runs for about 2 years. Every 3 months is called one cycle. So 8 cycles of 3 months duration we do, which is 24 months, 2 years. And we use 2 oral drugs. One is 6-mercaptopurine, and another thing is methotrexate. Most of these kids just come to OPD and go. Maybe nurses don't get to see them, but it is a very, very important cycle of the entire treatment. Why? Because that is the thing that will prevent relapses. So what we do during that time is to look at the general well-being. We ask the child to go back to school and follow all the routine things. When the child comes to us once in 3 to 4 weeks, we examine for any signs of recurrence or relapse, like look for lymph nodes and hepatosplenomegaly. And these drugs are very easy to give, and usually the child gets back to his normal routines during this phase. Learning here should be discipline and consistency is the most important thing that we have to learn here. Please keep counseling the parents that be compliant with the treatment, not to miss the doses. So now the child has completed therapy. What advice to give, how to follow up when the child finishes about 2.5 years treatment. So what advice? Child is completely normal as of other kids. This reassurance is very, very important for the parents as well as for the child, because they would have kept the child very safe and the child would have lost the contact with the environment. It's very important to recreate their new environment and reintroduce them into the society. The risk of relapse is there. It should be cautionary, but it should not cause any fear. Early signs of relapse, you should explain to them: prolonged fever, if there is any lymph node or anything, just they have to come to the hospital to show. And schooling, hygiene, growth monitoring, as we do for any pediatric child, we have to do. And we have to revaccinate these children because they would have lost the immunological memory of the previous vaccines. Just remember that these kids are normal and they may have to be seen once in 3-4 months in our hospital and look for any signs of relapse. But don't scare them that it can relapse. Please allow them to have a peaceful time, because they would have gone through a very difficult phase in the initial 2 years. Now, relapse in ALL can happen, but with treatment effectiveness, and if you follow the things that we did properly, definitely the relapse rates are lesser than 7-8% now. And most relapses happen at the end of maintenance or 1 year after completion. We call it as a very early relapse when the relapse happens ongoing treatment, early relapse, or sometimes late relapse. Common sites for relapse will be either bone marrow, but sometimes it can come back in the brain or it can come back in testis. So still there is a hope, because bone marrow transplants are quite safe now and treatment effectiveness is there, but there are new therapies as well. So very short point on one slide on recent innovations. So most of the nurses, or few of them, must have heard about something called CAR T-cell therapy. So this treatment may change the domain of ALL treatment in next few years, decade or so, because we may go away from using conventional chemotherapy and may look at something called cell therapy. So what is CAR T-cell therapy is, it is engineering the T cells, like making the T cells attack only the cancer cells so that the cancer is completely cured, and we need not bomb with lot of conventional chemotherapy. But how successful it will be is time only will let us know. But this is one of the innovations that have happened. And this is one of the girl who got the first CAR T cell. She's called Emily Whitehead, and Carl June, he received the Nobel Prize for this, and she is currently 10 years without cancer-free after she had relapsed multiple times on ALL treatment, and she's now cancer-free for 10 years with this CAR T-cell therapy. Just about 3 days ago, we heard in news from India that CAR T-cell used in a child has kept her 1.5 year cancer-free. This child is named Ishwari. So Ishwari is the poster girl for India. 9-year-old child who has been cancer-free for 1.5 years. She was relapsed leukemia relapsed ALL treated at Tata Memorial Center, Bombay. And I think we will have more success stories like this even in relapses. So my point here will be ALL is one disease which is much better than several other disorders, like even in compared to cerebral palsy or type 1 diabetes and things like that, other pediatric ailments, because the treatment is finite. If we treat it properly, outcomes are excellent, and the complication rates is becoming lesser and lesser as we become more experienced. So for a BALL, the outcome is more than 90% survival. For T-cell ALL, it is about 70% survival. The total duration of treatment is 2.5 years, as I already told, but it is very important in the first 6 to 8 months to be very careful. After that, the parents would have learned how to take care. And 6 months of intensive phase needs local stay closer to the pediatric oncology center. So it is not treating with drugs that makes a child come out of the disease. It is holistic care, and for that, the care is through your hands, and nursing team along with the family and the psychologists and play therapists are the ones that make the journey pleasant. So when I start a child on treatment, when in any of our pediatric oncology doctors start, we always want the journey to be smooth, because we do not want the parents to remember bitter events during the treatment. So for that, more than scientific thoughts, it is how we respond to the child is more important. So it is very important for us to urge that our team is as empathetic, as compassionate to the child as possible, to keep the journey of the child going through very safe and secure, and very heartening for the child as well. And these kids are actually more mature than the kids of the same age. You can see in them their differences. They actually are more brighter, and they are more courageous. They know what is happening on that day and things like that. So these kids can do remarkable things when they come out into the society, and they can win Nobel Prizes and things like that. So other important thing of role of nurses will be, as we already discussed, risk of infection. So you are the main people taking care. Pain and discomfort, which can be physical or sometimes just mental pain. And nutrition is very important. Getting a good IV access is extremely important, and counseling. A lot of times the doctors may not speak and spend time with the family. It's very important for the nurses, whenever you are going to the child, administer drugs, it's very important to see. So 7 things that any kid would like to listen is words like I love you, very sorry, please forgive, I am listening to you, it is your responsibility to get better, all these things. So please be very compassionate and treat the child as though you are doing it, you are meeting that child with a lot of compassion and lot of prayers. So ALL, if you see in this, the outcome is 90%, more than 90% actually. So if you see childhood cancers, the second one is ALL, overall survival is 83%. So childhood cancers are curable, and ALL is more than 90% curable. So it is one of the best cancers to have. If we treat it properly, it can get better. So most childhood cancers can be cured. And I would end by saying this. These are few of the photos. See, on the left side, you can see a kid having a hand rub in her hand. So she has already learned hand hygiene. She has a scissor, so she knows what medical equipment is there. The second photo is one girl who keeps a doll cannula bandaged whenever she gets admitted for high dose methotrexate. She keeps a bottle by the side, and always she checks weight of that child also. So that's how brilliant these kids are. The third photo is a child who is actually peeling off the boiled egg, saying that nutrition is very important. The fourth and fifth ones are toys that they use, and they know that they'll get back normally. The racing cars are there. That means the mood is very good for the child. And when they use these animals and play with them, that means the mood is good. So kids do not they are very resilient, and they'll come up victorious easily. And one of the photos that we have, last one, is one of our nurses who has cuddled the kid. Extremely important to have such instances, because kids, there's a lot more than just scientific treatment for these kids. Thank you.
Thanks a lot, Dr. Vinay. It was such a wonderful presentation. You have started from the journey, diagnosis, took across the journey and come up to the advances. I hope this is definitely a very good understanding for the staff who are taking care. And as you rightly said, I mean, it's worth treating these children and going through the pain, and we have to be supportive of them during the process. So it's quite true. So if we can request Ms. Lakshmi to continue with her presentation, we'll take up the questions at the end.
Yeah, just a second. I'm finding it difficult to switch to her presentation. Just a
Sure,
second.
no problem. In the meantime, one person has asked, she wanted to see the prognosis slide that you have shown. If you want, you can probably just explain what you've discussed in the slide.
It's a slide next to it. So prognosis slide is how ALL kids fare. So which slide? Is it the last slide that you were looking at? So maybe we'll go
You
on
were
to
talking about the overall survival.
Second last slide. Second or last slide.
Yeah.
This step, yes, this one.
Yeah. So see, 9 out of 10 kids are completely cured when we treat for ALL. Obviously, there will be some complications in few kids that may take up the life of the child, or sometimes relapses. But when we start treatment for any child, just think that we'll give them 100% cure. At least inside you should feel that. Make the parents also optimistic about it. And we should say that there is a chance that the child may not do well, or relapse can happen. Okay, but I think we should. This is one of the tumors that responds very well.
True. I think from your presentation, the take-home point that I would like to emphasize for the staff would be that, as you rightly said, if the mother is feeling that the baby is unwell, then we have to consider that and give very great importance to that. Because the neutropenia, steroids, all these medications will have a significant effect on the inflammatory response to the infection. So anyone who is unwell and has pain cannot be ignored is the learning point that I would want the staff to take home from this presentation. Over to Lakshmi, please.
Good evening, everyone. I'm Lakshmi, staff nurse in Yaswantpur Manipal Hospital in hematology department. I'll discuss today about chemotherapy administration in pediatric in ALL child. Today, what we are going to learn, that one some objectives I will tell. Scheme of chemotherapy drug in pediatric ALL, then general checklist of what we are maintaining in chemotherapy unit, and administration of drug, and highlight associated safety precaution. Then already Vinay sir has spoken about the phases of ALL treatment. I'll just tell about what and all medication will come in that all the phase. First will come induction. In that, first will give steroid. After that will come chemo medication like vincristine, daunorubicin, L-aspergillus, and methotrexate. Then second will come consolidation. In that, cyclophosphamide, cytarabine, and 6-mercaptan purine will come. Then third one is interim maintenance. In that, IV methotrexate and 6-mercaptan purine will come. Then fourth one is delayed intensification. It's like same in first induction period only, same. In that, vincristine, doxorubicin, dexamethasone, and L-aspergillus will come. And last will come maintenance. In that, this one methotrexate and oral methotrexate will come. Then and this treatment will go like 2.5 years like this. And we'll go to checklist, like when our babies and all will come to our unit. First we'll go to vitals part, like weight, height, then BP, everything. Then that day one of nurse will be there for that caring of that child, and we'll document the all vitals, everything. Then we'll send to the OPD to meet the doctor. Then after meeting to the doctor, then we'll go to protocol, what doctor is advising, what blood test will be there. According to that, we'll maintain the everything like blood test, port access, or dressing will be there. Everything will go in that. Then chemotherapy administration, how we are maintaining. First will come prescription, like doctor will do all the prescription, what medicine have to give for, what they are doing already. Then according to that, we'll go to preparing with the schedule, everything like protocol, what we are, this one, doctor is doing protocol, that one will go for preparing part. Then administration, then monitoring, what we are monitoring after starting the medication or after finishing medication. Then prescription will go, in that will come. We are maintaining like this, first patient name identification will be there. After that, it should be clear, like we should, if we are seeing, then it should be clear everything. Patient name, hospital number, then doctor's name, then date. After that, two cross clarification will be there, like one will be senior nurse and one will be side nurse will be there. They will cross check that doctor protocol and what we got the protocol, it's same or what. After that only it will go to medication part. See, here you can see like after giving preparation, who is preparing the medication and who is verifying like it's correct medication, what we given schedule, same dose mixed or not, whatever we are cross-checking everything, two name will be there. Then who is going to administer the medication, their sign also, name also will be there. Then preparation will go. This is our preparation room. In that, first after entering to the chemo medication preparation room, lamina hood we have. In that, first we'll clean the lamina hood with the, first we'll switch on the lamina hood, then we'll go, wait for 10 to 15 minutes, then we'll on the UV light. That is also will wait for 10 to 15 minutes. After that, we'll clean the lamina hood with the isopropyl alcohol. Then after that, we'll start our mixing process. Whatever we need, like a syringe, gloves, everything we'll keep inside. And in ALL, will come most of the medication is like freezing medicine. With the ice pack only, we'll sit in medication room to mix the medication. Then in left side, you can see how we are, after hand washing everything, we are wearing full PP kit. Everything will be there. After that, disinfection and all. Then it's coming everything, all arrangement, everything. Then how we are mixing the medication. Before mixing the medicine, we'll clean the that vial half. After that only we'll start to mix the medicine. Then we should know the things like chemotherapy. It's everyone knows like it's a high risk medication. For that, we should know the patient rights, 5 rights of the chemotherapy or patient. Then first will come to patient. After that, if you know the patient, then after that you have to know the dose of the chemotherapy drug. Then it will come to which route. Some of the medication will be there. Some of the medication will be there, IV, then IM or oral, anything we have to cross check. That is will be dose route. After that will come drug, which drug we are going to give the patient, it's correct or not. After that will come time. Then we'll go to rules of chemotherapy. Means first we should know patient, same patient we should know. After that our patient child protocol, then child in protocol, what drug and all will be there, and where our child is there, we have to know the things. this is our administration of chemotherapy. First, in checklist, first will come patient. We already told in first patient vital signs will be there, height, weight, BP, everything. In that, after that will be there blood test. In that blood test, some specific in chemo also some we are giving like vincristine or doxorubicin, anything. In that also some specific we want blood test. In that we'll do that one first. After that, before starting the chemo, we'll give any antiemetic. After antiemetic, we'll check the whatever we got schedule that is correct or not. Doctor sign is there or not. To verified nurse sign is there or not. After that, we'll go to the child. Then we'll check to the child identification, hospital number, name, everything. Then then first medicine will come vincristine. It is we knows already, like it is basic and drug, and it is a plant alkaloids. This vincristine should give only one route. It should be in IV, no any other route. And before giving vincristine, we should access the line. In that line, it's backflow, like blood flow should be there. Then only we can give that medication. Then maximum dose will be 2 mg, and all pre-chemo like CBC and sodium, potassium, everything will check. But most of the times we are checking in vincristine bilirubin level. If it is okay, then only we are going to give the vincristine. Then backflow should be there, what I told. Then if all vincristine always in our child, everyone will have central line, otherwise chemo port. In that we'll pay for central line, otherwise chemo port only vincristine. Then this vincristine will give in 3 syringe technique. Side effect of vincristine, like how it will come after giving vincristine, any side effect will be there, like IV extravasation. If we are not checking the backflow, if flow is not good or line is not good, then it can happen like this. Then next will come seizures, then severe food drops, constipation, jaw pain, or low sodium level. Then doxorubicin and daunorubicin. In that, this is also one type of basic and drug. It is anthracycline, and this also we should give only IV. This same like vincristine only we are following, but this one most of the time, first when we are going to give, we should check echo is done or not that baby. After checking the echo report only, we are going to give doxorubicin or daunorubicin. Then this we can identify the medication, like when we are diluting or giving to the patient, it will be red in color. Then we can give like it, yeah, it's doxorubicin or daunorubicin. By color only you can identify the medication. This also same, you have to check the backflow. Then dilution will come. Doxorubicin will dilute always in NS, normal saline. In 100 ml NS, we are diluting 1 to 2 hours. Then we should educate the patient, attend means patient, child parents and all, like when they are going to pass the urine, it can come red in color, because that medication only it's the red in color. Don't worry about this. Doxorubicin and daunorubicin, main side effect will come cardiac toxicity. For that only we are checking echo. After that only we are going to give medication, and it will also will cause IV extravasation, then mucositis and neutropenia. what I told, it's basic and drug. The basic and drug, we will have like after extravasation, what to do. We are having this management and antidote also. For anthracycline, doxorubicin, daunorubicin, will manage to with the ice pack. Then we'll go to antidote. Topical DMSO for 50% we are applying, and vinca alkaloids in vincristine and all we are using heat or warm pack. In that, antidote will come hyaluronidase. Uh, then L-aspergillus. Actually, we are using in our department for child peg L-aspergillus. It's an enzyme, and its root will become like we can give IV and IM. Both we can give. After any blood test, we are checking CBC, bilirubin, and the albumin. Then administration. When we are giving IM, it will come maximum dose 2 ml. Then when we are going to give for IV, it will come like a two will come, like first session will come like we'll mix the medication. It's 1.2 ml or 1.5 ml. It will come units. 3075 units or anything will mix with 100 ml. From that we'll take 1 ml. In that we'll mix 10 ml normal saline. We'll give for start dose. Any side effect, any reaction, anything is coming, we'll see first. After observation for 15 minutes, we'll start the full dose of L-aspergillus medication. It will go for 1 to 2 hours infusion, and after that we'll observe for the child in unit 2 hours. When we are giving this L-aspergillus, L-aspergillus, we'll keep always avil, hydrocort, adrenaline available. If we are waiting for 15 minutes after giving start dose. If any reaction, anything happen, for that we are keeping everything always ready. This is the side effect: anaphylaxis, low albumin, then pancreatitis and thrombosis. Cyclophosphamide, next alkylating agent. This is also we are giving IV only. Then all the lines would be secure, everything. Then we'll check RFT, then bilirubin. This administration, this one, whenever we are getting protocol, we are getting schedule from doctor order, we will give for dilution, because this one will take a long time to dilute cyclophosphamide. Then before this medication, before starting, will no need any prehydration, anything, we can start. After that, after finishing the medication, we should give mesna. Like it will, this cyclophosphamide will cause hemorrhagic cystitis. For reduce that syndromes, we can give mesna. Now, this is side effect: nausea, vomiting, hemorrhagic cystitis, and myelosuppression. Then high-dose methotrexate. High-dose methotrexate always we are mixing in a normal saline or 5% dextrose. Before giving before starting methotrexate, we are starting prehydration. Like normal saline with the soda bicarbonate will start. Then we'll start to send urine routine to check the urine pH. Then before 6 hours, we are starting prehydration. Then we'll start the medication. When urine pH will come to 7 normal, after that only we'll start the methotrexate. Then after methotrexate starting, first dose will come 300 mg or 400 mg according to doctor orders. In 100 ml NS, we'll mix the medication and we'll start for 1 hour. After finishing that medicine, we'll start for 23 hours. 23 hours of continuous infusion. Then always we should remember, after finishing methotrexate, we should give leucovorin 3 dose. This is how we are connecting the medication and all. This cytarabine, it is a irritant drug. It's also we are giving a IV and subcutaneous also. When we are giving cytarabine, we'll check the LFT and RFT. Then admission, this we can give through 1 hour infusion also, and we can give IV bolus also. Then symptoms, side effect will come. Cytarabine syndromes, most cytarabine syndrome, in that will come first fever, after fever rash, after that ocular toxicity, nausea, vomiting, hair loss. Then side effect of oral tablet, steroid, hypertension, hyperglycemia, then pancreatitis, psychosis, myopathy, then trace, then markiptopurine, hyperbilirubinemia, then hypoglycemia. This is mucositis grade. Procedure, this is chemoport access, how we are accessing the port, how we are securing the line, it should not come out and all. This is methotrexate. After starting methotrexate high dose, so we are going to lumbar puncture. In that first procedure, lumbar puncture, we are arranging the things. This is our procedure, how we are doing. Babies lie down, cleaned everything. After that, we are going to take sample. Then we are pushing methotrexate. Then after finishing the procedure, baby should lie in a flat position for 24 hours. Then bone marrow aspiration. Thank you.
Thank you so much, Lakshmi. Again, a very practical and clear explanation of whatever is being done every day in the wards.
Yes, ma'am.
Are there any questions or comments? So we have a question in the chat box. Dr. Siaram has asked, any preference of route, IV or IM with Lyonase? Dr. Vinay, you want to take up?
Yeah, so see, previously we used to do mostly IM. So one thing with IM, what I feel is you'll give off the full dose and look for any reactions. Okay. In IV, when we give, there is a chance of the test dose being used, and if there is reactions, we can stop or we can decide what to do. Previously, we used to think that giving IM will increase the duration of levels, but it is very clear with pegaspargines that the efficacy and maintenance of 14 days levels is very good with IV. And with the recent publications of plain L-aspargines not being very effective in the brands that we get in India, sometimes giving pegaspargines IV is preferred over IM. But still, I think it is debatable. Few centers adopt the thing that is more preferred for them. Siaram and Dharini, you could add on what you usually do.
So we are actually using only pegylated asparaginase. For most of our patients, we try to share and then cut the cost on that. So practically when we were giving, we were using IM. Because of the risk of the allergic reactions with the IV, which can be quite severe. So IM was the initial thing. But nowadays, I think with the availability of newer brands of pegylated asparaginase at very cheap rates, so I think we are already moved into complete pegylated asparaginase.
IV, right?
IM.
Okay,
IM.
Okay,
Yeah.
fine. Okay.
Yeah. So IM for young kids, muscle mass is problematic. That's what CRM is worried about.
True.
In that sense, probably to ensure bioavailability, yes, we can give IV, but yeah, with the monitoring. So do you keep the patients for in the hospital for 1 full month of induction therapy?
No. So usually what we are doing is we try to the day we get admitted, if the bulk and things are not very high, we hydrate very well for 5 days with allopurinol. We try to get in the chemo port before the platelets drop very significantly. Day 5 is the usual time when I get in the port, 5 to day 7. And during the same time as port, I do of the first LP, so that and try to discharge by day 8 to day 10. Few kids end up having some tumor lysis, some renal replacement and all. Those kids tend to get prolonged. But usually timeline in a garden variant ALL, my discharge, usually what I feel is early discharge is preferred. Educating parents, I feel, has been the best one. I thought I'll put one photo of how our parents send I missed it. So what I am following now is parents are taught to maintain a monitoring chart at home. They write the amount of intake, output, number of times stools passed, temperature checked 3 times a day, and any remarks at the end. So something of this sort. Patient reported patient reported monitoring is being done. It is really helpful. It assures the doctor and the nursing team when the child is on induction at home. I'm sure not all parents may be very intelligent to do that, but whoever we can educate, literacy doesn't come in the way. I think if we educate, most parents are very punctual to take care of their children as nicely as we can do at in the hospital. Once the fluid requirement goes and once the blood component requirement is not there, tumor lysis is off, I tend to discharge the kid in induction at the start.
That's really a great point. I mean, it gives them a psychological feeling of being at home as well. And I completely agree with
And
that.
I say the reinduction rates are not very high. Fingers crossed. Infections are quite low. We are able to manage without a febrile neutropenia in induction. 1 out of 5 kids come for at least one admission in the induction for febrile neutropenia. It's more in the consolidation that we see that they come and get admitted for 3-4 days, and that's the time when we may have some bacterial infection. But induction somehow the kids do better as weeks progresses. 3rd, 4th week we cross, we are very safe.
True. Completely agree. I think CRM has also agreed that they are also following the same policies. Here, I mean, we usually discharge them after the first vincristine dono. We usually do the LP on day 8 and pick or port based on their age. We usually try to do it at the end of induction. If someone is having a very difficult venous access, then probably we'll do it with week 3 LP. That's what we follow because usually, I mean, under our anesthesia team, they are very stringent that they need 1 lakh platelet and we need to pump in a lot of blood products in the first 2 weeks. So, and considering the infection rates and managing, and usually they are not very ready at the first week to have all these, to arrange the funds and all that. So we either prefer week 3 or 5. So,
yeah, completely agree.
But yeah, I know the
very good time.
yeah, the central venous
End of
access
induction is
devices,
probably
I
the
think
best
they
time.
have true. Because usually the counts are completely recovered for most of them and we don't need any support. And we are least worried about the infection aspect as well. So there are no more questions on the chat box. With this, then I would like to thank Dr. Vinay and Ms. Lakshmi for a really comprehensive overview of the childhood ALL. It was a lot of learning points for us also. And thank you again very much for your time. And we'll close the session. Over to Manisha. Thank you.
Thank you. Thanks for the opportunity. We enjoyed as well. Thank you.
Thank you, everyone. Bye.
Thank you, everyone. With this, we will conclude this session. I would request all the participants to just fill the feedback form. I have shared link in the chat box. Please fill your feedback form. Thank you.
Thank you, Manisha. Thank you.